hurts a lot going in and it hurts a lot coming out. Luckily, coming out is quick. Like a patient has told me, it's like lightning striking. Like it's fast, but it hurts a lot. Going in, it hurts and it can take a little bit of time. So we would want to pre-medicate the patient before they put it in and when they take it out. They do use lidocaine to numb the skin, but if you think about the fact that it's going all the way into the pleural space, it gets past where the numbing is eventually, and it is uncomfortable. And patients will complain about pain at the chest tube site the whole time it's in. And again, it's just because the size of the tube, it's between two ribs, it's just plain uncomfortable. So they may need some oral like pain medication just while it's in. Some people get used to them kind of who've had them a lot, but it's just not a very comfortable thing to have in for sure. So you would get this set up. So basically, we use it right to drain, and they'll talk about in the video. We're draining either air or fluid, blood, serous fluid, whatever, from within the pleural space, which could be there for a lot of reasons. It could be cancer that caused it. It could be an infection that caused it. It could be a pneumothorax, a collapsed lung that we're trying to reinflate by pulling the air out and allowing the lung to reinflate. So there is a collection chamber here. So if it was air, obviously, you're not going to see it. All we're trying to do is reinflate the lung. The majority of time, though, there's fluid there that we want to drain. So you're just keeping track of the drainage. At the end of your shift, you mark it with the date and time, and then each shift going forward. So similar to like the wound vacs, right? We would expect that the drainage will decrease as the time goes on. So when they first put it in, let's say it may drain, you know, right up to like, sometimes I've seen 400, 500, 600 right away. So then you mark it when it's put in, the date and time, and then every shift. And then you're just kind of keeping track. So and even post-op, a lot of times it'll be post-op some type of surgery. You're expecting bloody drainage, right? And a decent amount to start with, but it should get less and less. So like an NCLEX question might be, you know, which one of these situations requires immediate intervention? So if somebody's been draining like 100 mLs of bloody fluid post-op, and they drain 400 mLs in a few hours, that's a problem, right? They're obviously bleeding somewhere at the site. So we're gonna need intervention for that. So we're just keeping track of the fluid drainage here. This is suction. Not all chest tubes are ordered to suction. So you can have a chest tube that's just ordered to gravity, and if that's true, then you would just not even have the suction on there. But if it's ordered to suction, then we have to hook it up to suction, and there's a couple different types of setups of a chest tube. So obviously your clinical instructor would help you to start with, but the doctor's gonna order it to like 20 centimeters of suction, 30 centimeters of suction, 40 centimeters of suction. So basically you put it to suction, and then you turn the wall suction to get it so that it stays at whatever amount of suction the physician's ordering. And again, the suction is just increased pressure trying to drain some of that fluid or blood. There is, in all the chest tube setups, a water seal chamber. And when you think of water seal, just think of the word seal, right? So where the water seal is, you're gonna fill it up, and the water seal chamber, you're gonna see the inhale and exhale, and you might see a bubble every once in a while as people breathe in or breathe out. But you should never see continuous bubbling in the water seal chamber. Remember, it should be sealed. If you see continuous bubbling in the water seal chamber, you've got an air leak somewhere. And so you would notify the physician. Sometimes they can fix it, sometimes they can't, but there is somewhere it's leaking air. And it's not that that's hugely dangerous to the patient, but with the air leak, you're not gonna get the fluid draining the way it should, because it's not like a tight seal around the tube. So they may need to do something with that.
So there's like an air leak somewhere in the tube?
No,
Or
it's
in the patient?
it's in the patient, right?
Yeah, like you could hear
Yes.
it if you listened for it.
Yes.
Yeah.
Sometimes, but if it's little, you might not hear it, but you'll see it here first with the water bubbling.
Yeah,
So-
okay.
So basically, there's 3 chambers: the drainage chamber, the suction chamber, and the water seal. Suction is sometimes used, sometimes not used. Just some important things, right? Is we always, like a catheter, always should be below the level of the lung. You're not going to lift it up like this. They say not to have dependent loops, same as a catheter, just because it slows down the drainage. You never clamp a chest tube unless the physician orders it. So, because what would happen if we clamped this?
Increases pressure.
Right, the pressure then builds up in the lung. So it could collapse the lung, could cause problems. Now, just so you know, there may be times that the physician orders us to clamp it. Like it's getting to the end, they think they're ready to take it out. They may say to clamp it and see how the patient tolerates it. But we never do it unless there's an order. We also never milk or strip the tube, which we used to do way back when a lot. No more milking, stripping any type of tubes. That's all no more. So you just kind of keep an eye on the drainage. The drainage is generally never that thick, so it's not like it's going to clog the tube up to begin with. I think when we used to milk it, it was like to get the last little bit out, but we don't do that anymore, again, because of the pressure. So there should be a dressing around the insertion site. Usually it's that, Mary showed it last week, that Vaseline petroleum gauze, just kind of around the site, and then a dry sterile dressing. There's one, and I don't know, this might be in the situation you're gonna do too. Sometimes when they put it in, air builds up just under the skin, subcutaneous tissue as they go in. It's called crepitus, and it almost, you'll see it, and it almost feels like that bubble wrap if you kind of push on it. If the patient has it, we generally mark it with a pen. And so we can, just like, let's say an infected arm, or so we keep an eye on it just to make sure it's not getting a lot bigger. It generally doesn't. It's usually with the insertion site, they get a little air under there and it just stays there. The connection is usually taped here. And we just want to be careful with this container that it doesn't get stuck under the bed when the bed goes up and down. Because if for some reason this tips over, we just pick it back up, right? But if it gets cracked or something happens to it, you got to change it out. And not that we can't do that, but the less we open the system, the less there's infection, the better it is. I think that's all I'm gonna say, because I think there's some questions in your scenario, and we'll make sure we go over all the rest of the troubleshooting after you take a look at it.
So if there is an air leak, is that like a doctor problem?
Yes, there's nothing we're gonna do for an air leak. Yeah,
Just let the doctor know.
just let the doctor know, and they'll decide what to do with it.